Our next talk will be given by Dr. Amy Giuliano from Massachusetts Eye and Ear and Harvard Medical School. She will be presenting thyroid gland malignancies, the good, the bad, and the ugly.
Hi, I'm Amy Giuliano. I'm a head and neck radiologist at Massachusetts Eye and Ear in Boston. And today I'll be speaking on thyroid cancer, the good, the bad, and the ugly. And I want to thank Ilona Schmalfus for the invitation to speak. Here's the outline of my talk. I will start with thyroid cancer types and show some examples, and then unusual types and mimics, workup of a thyroid nodule, and then we'll discuss some tools for predicting disease trajectory. The underlying theme is that it is not about who has cancer, but who needs surgery and treatment. Let's start with thyroid cancer types. These are primary to the thyroid, and most of them are of follicular cell origin, and of those, papillary is the most common type. Hurdle cell used to be considered a subset of follicular cell tumors, but now they're recognized as their own separate category. Medullary thyroid cancers originate from parafollicular C cells, so they make calcitonin and not thyroglobulin. They can be seen in some syndromes and can be familial or can be sporadic. I just want to mention quickly NIFTP in case you do come across this term. This has been a hot topic among pathologists in the last couple of years. It used to be referred to as a papillary thyroid cancer with follicular features, but now it's considered a neoplasm and not malignant, not a cancer, and not within the papillary category. And they have to be diagnosed by surgical specimen where you see a complete intact capsule. There are other types of thyroid cancers. They are rare. This includes primary thyroid lymphoma, sarcoma, metastatic disease to the thyroid gland. And then you can see thyroid cancers in not orthotopic thyroid gland in its usual thyroid bed, but in ectopic thyroid or in thyroglossal duct cysts. All right, how do thyroid cancers present? Well, there are a few different ways. One is when a patient presents with symptoms because of a thyroid lesion, but it's not recognized as such because the symptoms are not obviously localizing to the thyroid gland. Here's a 60-year-old male with neck discomfort, just kind of generalized. Got a CT, and it shows a hypodense lesion in the left thyroid lobe that's replaced most of the thyroid lobe. On ultrasound, you can see this multilobulated nodule with internal microcalcifications. But in addition, just lateral to that, there is a solid and cystic lymph node with microcalcifications in the solid part. This was biopsied. This was a papillary thyroid cancer, tall cell variant. And molecular marker testing indicates a BRAF V600E mutation. And that is a mutation that's associated with an aggressive phenotype and aggressive disease course. On the ultrasound, we looked up and down, and there was another node that, although it is small, is clearly abnormal. It's heterogeneous. There are some internal echogenic foci that are probably microcalcifications and lots of vascularity. So ultrasound offers excellent characterization of nodules and nodes. So at our institution, whenever we do a thyroid ultrasound, we always do a nodal survey as well in case we pick up some abnormal neck nodes. An 89-year-old female, the doctor felt a large left neck mass. On CT, indeed, there is a big mass, and it looks like it's originating from the thyroid lobe, but continues superiorly along the retropharyngeal region, and then also invades into the vein, so there's now a tumor thrombus. She went on to get a chest CT that showed these small, round pulmonary nodules that turned out to be metastatic disease. This was a malignant follicular neoplasm. And when lesions are really big, ultrasound becomes a bit limited because the probe only has such a big footprint that allows interrogation of that immediate area. So a CT would allow mapping of the entire extent of the tumor. And note that thyroid lesions can extend up to the retropharyngeal space, and as well you can get retropharyngeal nodes as metastatic nodes in a thyroid cancer. A 56-year-old male with right neck swelling noted after an injury. There's a big thyroid mass on the right that's heterogeneous, calcifications, but also big bulky neck nodes that have a similar appearance. This was a hurdle cell neoplasm, considered a distinct subtype from follicular tumor. And they are considered malignant pathologically if the pathologist can see invasion into the capsule or vessels. A 70-year-old female with difficulty swallowing. Here we can see this heterogeneous mass that's posterior to the thyroid and posterior to the trachea. But there is invasion into the party wall, into the esophageal wall, into the trachea. There's also a vocal cord paresis, which is never a good sign because that indicates invasion into the tracheoesophageal groove where the recurrent laryngeal nerve is. And we can see a sclerotic bone lesion. This lesion was biopsied and it was a medullary thyroid cancer. They have a propensity for metastatic disease to the lungs, bones, and liver. So while we have a next CT, we better check the lung apices and the bones. And vocal cord paresis is an ominous sign. An 84-year-old male with hemoptysis had a CT of the chest. And there is this lesion in the region of the thyroid isthmus that's eroding and invading into the cricoid cartilage and this little bump in the trachea indicating probable tracheal invasion. Then he got a dedicated neck CT that shows this same mass growing upwards and invading into the thyroid cartilage. And we can see the lesion that is in the thyroid gland. This was a papillary thyroid cancer that was eroding thyroid and cricoid cartilages and tested BRAF positive. So again, an aggressive phenotype. 57-year-old male with left vocal cord paresis. We can see the big ventricle and the pointed true cord indicating the paresis. And indeed, there is this lesion in the medial aspect of the left thyroid lobe that is growing towards and likely invading the recurrent laryngeal nerve. On ultrasound, we can see this hypoechoic nodule that is growing towards the tracheoesophageal groove. So this was a papillary thyroid cancer. Again, vocal cord paresis is an ominous sign. And on our reports, we have to say if we see a lesion close to the RLN or the trachea, because those are useful pieces of information for the surgeon to know in case they're planning for surgery, which would make the procedure much trickier. A 53-year-old female presenting with Horner syndrome, and there's also a neck mass. On ultrasound, we can see this lobulated hypoechoic nodule with microcalcifications, and on CT, we can see it invading posteriorly towards the lateral part of the vertebral body, and that's where the sympathetic trunk lives, going up and down the spine. It's also going towards the trachea, esophageal wall. This was a medullary thyroid cancer, and just remember, sympathetic trunk running lateral to the vertebral body. So if there's a Horner syndrome, it could very well be from this lesion. She went on to have a PET CT, and we can see metastatic retropharyngeal node, liver lesions, and a bone met. So remember to check for retropharyngeal nodes and remember the propensity of medullary thyroid cancers to go to not only nodes, but the lungs, liver, and bones. Another way thyroid cancer can present is by a palpable neck node because we're actually feeling the metastatic node. Here's a 13-year-old male, had an accident playing basketball and then felt nodules. So here we can see these bulky lateral compartment jugular chain nodes, also a retropharyngeal node, and a thyroid lesion. On ultrasound, we can see the microcalcifications in both the node and the primary thyroid lesion. This was a papillary thyroid cancer. Another way that thyroid cancer presents, actually feeling the nodule itself in the thyroid gland. Here's a 50-year-old female, felt a lump in the neck, normal TSH, so got an ultrasound. Here's a nodule at the isthmus, a bit exophytic, so likely what she was feeling. But in addition, ultrasound picked up another nodule that she couldn't feel that was in the lower pole with microcalcifications, some ill-defined margins. So ultrasound is excellent at evaluating for all nodules, whereas CT is a bit limited. It tends to either, it can overestimate or underestimate. On biopsy, the isthmus nodule turns out to be FLUS, follicular lesion of undetermined significance, which means it needs further workup, like another FNA or molecular marker testing to see if it's actually benign or malignant. The right thyroid nodule turned out to be a papillary. So the lump she felt was not the one that was definitively malignant. It is the other one that got picked up by ultrasound. A 57-year-old male who felt a thyroid nodule got an ultrasound and then eventually led to a PET CT. And you can see this very FDG avid lesion that grows up from that grew upwards from the thyroid lobe, and also an FDG avid metastatic lateral compartment node. So this was an anaplastic thyroid cancer, extremely aggressive. And you can see here, despite treatment, it just progressed very quickly, just over the course of a few months, until at the end it was invading into the larynx, esophagus, cartilage of laryngeal cartilage, and encasing the carotid. Another way a thyroid cancer can present is as an incidental thyroid nodule. So here's the 35-year-old female who got a CT for neck pain. And here's a little nodule. So this is not causing the neck pain. So this is an incidental thyroid nodule. Well, she's 35. This is small. So by different criteria, this actually didn't really warrant a workup, but she did end up getting an ultrasound. And on ultrasound, you see this lobulated hypoechoic nodule, taller than wide. And because it is small in size by any society guidelines, it qualifies for surveillance, but not FNA. So we followed her. A year and a half later, she comes back for follow-up. The nodule looks just about the same, but now we see some abnormal neck nodes. At right level 4, we see one node that has distorted architecture, and another node that is solid and cystic with a focus of microcalcification. And comparing with CT, these corresponding nodes on CT really don't look that suspicious. So CT is not great, but ultrasound is really excellent at being able to characterize these nodes very well. So we ended up doing FNAs of both of these nodes, and we sent them for thyroglobulin analysis as well. So they came back as papillary thyroid cancer, classical type, and BRAF positive. So just a word about how we think about incidental thyroid nodules on imaging. So on ultrasound, it's already been clarified by TIRADS, which gives a very convenient algorithm, which Dr. Yoshimi Anzai spoke about in the last talk. But what about cross-sectional imaging? So Jenny Huang and her team, at the time she was at Duke, came up with a 3-tiered system, and they published it in a white paper for ACR in 2015. And basically, it's reliant on features seen on CT, like is it invasive looking? Are there suspicious nodes? And then on PET, if it is FDG avid. And then patient age, if the patient is young, and especially if it's a pediatric patient, that warrants a workup at a smaller size. And then if the patient is over 35 years old or at 35 years old, then workup starting at 1.35 centimeters. And just a word about when a thyroid nodule should not be considered incidental. So these are the factors that increases suspicion that when you see a nodule, it may be malignant. One is if it's on the same side as the vocal cord paresis. We already mentioned that because the nodule could be invasive into the RLN. If there are bad nodes, so if maybe they're metastatic and coming from a primary lesion, and it might be that thyroid nodule. In a previously radiated neck, because that increases the risk of papillary, and then in a patient with MEN syndrome, because that increases the risk of a medullary thyroid cancer. Finally, we can pick up a thyroid cancer if we're looking for it. So if there are patients with a history of thyroid cancers undergoing surveillance imaging. Here's the 47-year-old female with a history of papillary, underwent ultrasound, and this node looks very thin, elliptical, normal size, not really that big or, round, but we can see these echogenic foci, and also that this echogenic part breaks through and invades into the cortex of the lymph node. So this indeed turned out to be a metastatic node, and ultrasound offers exquisite resolution and characterization. A 43-year-old female who had a left hemithyroidectomy for papillary, and then 5 years later, came back. So she had a completion thyroidectomy, and at 5 years out, we picked up this hypodense node, cystic node at level 2, and this was a metastatic disease. So just a word about differential diagnosis of a level 2 cystic lesion. So here was our patient with the metastatic recurrent thyroid cancer in a level 2 node. Another patient also with a metastatic papillary thyroid cancer, this one with calcifications. And then the very famous branchial cleft cyst, a second branchial cleft cyst. But also other lesions like suppurative adenopathy with lymphadenitis in this patient with a retropharyngeal abscess. This here was a lymphatic malformation and an epidermoid cyst. So we have to be aware of the differential, and the most important thing is to not miss a malignancy. 75-year-old male with a history of invasive papillary thyroid cancer undergoing surveillance. So in November 2016, there was a recurrence in the pretracheal region. He went to surgery, this got resected, and then he was followed. September 2017, not too much, maybe some post-radiation, post-treatment change. January 2018, something hazy, maybe still post-treatment, hard to say. And then another half a year later, it's a little bit more, so maybe this should be suspected, but at the time it was still a bit equivocal. And then April, he came back for another scan. This was the next CT. The contrast really wasn't in the vessels, so we just see this heterogeneous soft tissue. But thankfully, he also had a chest CT in the same sitting, where the timing of the contrast was a little different, and the contrast was mostly in the arteries. And now we can see this abnormal soft tissue encasing the artery. This was a papillary classical type, BRAF positive. And here you can see on the coronal of that chest CT, this recurrent thyroid cancer encasing the vessel. He got an ultrasound as well, but this was tough because it's really now getting really low down in the neck, very deep. So ultrasound has its limitations. Sound waves can only reach areas that are superficial that we can see, but retrosternal is tough, retropharyngeal is tough. But CT can be hard too. So for the lower neck area, we only saw it well for the first time when he had a chest CT, when the timing was in the arteries, when his arms were up. So, and also the bolus sometimes with the injection can cause a lot of streak, and that can limit the area. So we have to be very vigilant, especially if we know where the tumor had been before, where it had occurred before, to optimize imaging protocol to help us see the area that may be suspicious. All right, some unusual thyroid cancers. This is a 47-year-old with shortness of breath and chest pain and a rapidly enlarging neck mass. So here we can see it's very smooth, very homogeneous, pretty much replacing the thyroid lobe, but maintaining that smooth capsule. It's hypodense. And on ultrasound, again, it is very smooth, very homogeneous, very hypoechoic. And when you see these features, along with the fact that this is a rapidly enlarging neck mass, you have to suspect lymphoma. And this was what this was. This was a diffuse large B-cell lymphoma. 77-year-old female, history of Hashimoto, which increases the risk of thyroid cancer. Again, the history is a rapidly enlarging neck mass, so we're already worried about potential lymphoma. So we see in the left lobe this homogeneous, smooth lesion that's expanding the thyroid lobe. And then on the right side, a bit more heterogeneous. On ultrasound, we can see that the left lobe, again, is smooth, hypoechoic. This was the lymphoma. Whereas the right side is a bit hypoechoic, but it's kind of lumpy. And that's a very typical look for Hashimoto. Of course, we can't be sure, and sometimes we end up having to do an FNA anyway. So this patient in the left lobe had a lymphoma associated with Hashimoto. So again, Hashimoto can be hypoechoic, but usually heterogeneous and a bit lumpy, as opposed to lymphoma, which is very smooth. 59-year-old female with neck swelling. So here it looks almost cystic necrotic, bilateral, asymmetric, with some retropharyngeal effusion, which is really unusual. So I even thought at the time, could this be a third or fourth branchial anomaly, piriform sinus fistula, causing recurrent thyroiditis? She came for an ultrasound. It looks very heterogeneous, both sides, and we ended up doing an FNA. The FNA came back AUS, which is atypia of undetermined significance, so it requires further workup, but it might be a follicular or papillary type tumor. Or adenocarcinoma. So that path report was strange too, AUS versus adenocarcinoma. So she came back for a core biopsy. And the core biopsy just showed inflammatory tissue. So because the mass is so unusual and it's really growing very rapidly, she ended up going to the operating room. At the same time, on imaging, in the chest, there are these lung nodules that look pretty ominous. And also at the base of tongue, there's this kind of thickened soft tissue, hard to know really what it was. And it turned out that this patient had an EBV positive B-cell lineage lymphoma. And it was lymphoma in the thyroid, in the base of tongue, and in the chest. So this is highly unusual case. Nobody expected it. It's just to show you that, you can be surprised, and ultimately tissue sampling is the way to go. But typically speaking, lymphomas tend to be homogeneous and smooth. Here's a 19-month-old female with a neck lump. This turned out to be Ewing. Another patient with a thyroglossil duct cyst, classic location, but with heterogeneous enhancing tissue inside that's heterogeneously hypoechoic with microcalcs. This was a papillary thyroid cancer in a thyroglossil duct cyst. All right, some mimics. This was a patient with vocal cord paresis. This turned out not to be a tumor of the thyroid gland, but an adenoid cystic carcinoma that infiltrated into the thyroid, coming from either microciliary tissue in the trachea or perhaps the hypopharynx. Another patient, this irregular ulcerative lesion that turned out not to be of the thyroid gland, but an invasive squamous cell carcinoma of the trachea invading into the thyroid gland. Another patient with a history of left glottic squame getting surveillance CT. And here is this hypodense infiltrative lesion in the thyroid that was very ill-defined on ultrasound. We biopsied it. It was a metastatic lesion from the larynx cancer. Another patient had papillary, had a total thyroidectomy, and would come for surveillance ultrasound. And then we found this thing that had all this shadowing, and we had no idea what it was. But because of the history, of course, we were worried for a recurrence. So same day, he had a CT as well, which showed this kind of bulky looking lesion, but fairly well defined, which is not how we usually see metastatic disease. But because it's strange enough, and with the history, the patient did go to the OR, and this turned out to be a retained sponge, a gossypiboma. This is another patient, 56-year-old female, came for an FNA. So I was going to do her thyroid nodule biopsy when we scanned and saw this linear echogenic focus, which looked like it might be calcification, but why is it in a straight line? So I asked her, did you ever have any other imaging? Did you ever have a CAT scan? And did you ever have any trauma or maybe swallowed a fishbone or something? And she said, yes, in fact, I did swallow a fishbone years ago and underwent workup. It really hurt, and then gradually it kind of went away. So she got a CT, and we can see this linear calcific density traversing the thyroid lobe from kind of the hypopharynx area. So she went to the OR, and this did turn out to be a fishbone that somehow penetrated through the hypopharynx and got organized in the thyroid gland. All right. Workup of a thyroid nodule. So if we need to detect cancers, it could be a big mass, a metastatic, node. We do a biopsy. But what about a thyroid nodule? They're so common. Which ones do we biopsy and which ones do we not? So here's the typical algorithm tree. You check the TSH. If it is a hyperfunctioning nodule, they usually go to nuclear medicine. If not, they go to ultrasound. And then the main decision is no follow-up, surveillance, or FNA. So different guidelines have been published over the years for when to do an FNA, when not to, based on different features. And Dr. Anzai in the last lecture talked about TIRAD, so I won't go into it too much. Basically, it's on sonographic features of the nodule. And conveniently, you can get points assigned. You tabulate the points together, and it spits out what to do. Do you follow? Do you do an FNA? So now, let's say we've done an FNA, we have to be able to understand the cytology report. So how are thyroid nodules reported by the cytologist? And now it's basically by the Bethesda system. So you get categories 1 through 6. 1 is non-diagnostic, try again. 2 is benign, you just follow it. 6 is clearly malignant, you have to do a total thyroidectomy. And everything in between is kind of hard to know. Is it really malignant or is it not? So the usual management is you either repeat the FNA, you take out just that part and analyze the lesion. But now there is molecular marker testing available, and they really help to determine if you see mutations that indicate that this is a lesion that may be malignant. So oftentimes with our patients, if they come back AUS or FLUS or even Bethesda 4, they come back, we do a repeat FNA, and we send it for molecular marker testing in case the repeat FNA again gives you something that is not 2 or 6. So now we get a pathology report. It does confirm a malignancy. How do we decide how bad a thyroid cancer is? Well, the TNM system is pretty good for most cancers, and that's in the AJCC. That's geared towards predicting survival as opposed to disease recurrence, because a patient can live with disease and still survive pretty well in the setting of a thyroid cancer. Going from the 7th to 8th edition, generally speaking, everything has been downstaged because increasingly it's recognized that patients have a low risk of dying from most thyroid cancers. So going from 7th to 8th, you can see that in the 7th edition, if you have minimal extrathyroidal extension, it gives you a T3, but now that's been removed entirely, and all that matters is gross extension. And then also level 7 nodes have gone from 1B down to 1A. The other is staging. After you have the TNM, which stage are you? So the age cutoff has changed. So let's say I'm 50 years old. By the 7th edition, if I have a T3M0 lesion, I am stage 3. But by the 8th edition, if I'm 50 years old and I have T3M0, I'm actually stage 1. Also, the T stages have moved down. So let's say I'm 60 years old, I have a T3 lesion. I would have been stage 3, but now I'm stage 2. So generally speaking, everything has been downstaged because most thyroid cancers really are not fatal. But is TNM the best way to think about thyroid cancers? Are there other methods that can add information? What are the limitations? Well, the histologic subtype should matter because they determine sometimes, a lot of times, survival and biological behavior of the tumor. But the TNM system for differentiated and anaplastic thyroid cancers lump them all together. Many patients with residual recurrent tumor actually can live with stable persistent disease for a long time, even when there's mets. But then again, there are those who don't. So are there other, tools in our armamentarium? Well, one is pathology, size, invasion, distant mets, that's already incorporated into the AJCC. And then you can add tumor dedifferentiation. But what else? What else can we use to help stratify patients and to help predict survival? Well, in radiology, it turns out that the size of the met actually helps to predict. So if these are big nodules, big bone mets, big CNS mets, they're worse. Mets that don't take up iodine because it means that they have dedifferentiated. And mets that are FDG avid. But what else? What about genetics? So that's where molecular markers come in. They indicate that there is a change in the basic unit that forms, genes and epigenetic abnormalities. And they can predict whether disease course is milder or more aggressive. And there are some known ones that have been worked out, like we already mentioned, some BRAF mutations in the setting of papillary. They indicate a more aggressive clinical course. And there are lots of other pathways as well. But basically, knowing the molecular alteration in a tumor helps to personalize the therapy. We can understand the tumor, we can understand the biologic behavior much better by its genetic nature, not just by TNM staging. And if the patient needs specific therapy that's targeted to the mutation, that can happen. If the patient should need clinical trials for, immunotherapy, we can know what the genetic mutation is and match them with the appropriate clinical trial. At the end of the day, this helps to avoid overtreating patients with the more benign forms of disease, which is most of them, and to avoid undertreating patients with aggressive disease, which is the minority. This is just an example to show Peter Sadow is a good friend and colleague of mine who is a pathologist, along with other pathologists at our institution and medical oncologists, published this paper just showing patients that has been analyzed. And you can see I just want to show the features. They analyze the histology, the different histopathologic features, but also any genetic mutations and epigenetic factors in these mutations. So you can really get down to characterizing each tumor to its specific character and distinguish patients and distinguish their tumors in a very individual way so that the treatment can be tailored towards that. So in summary, thyroid cancers include a wide and heterogeneous group of disease that can exhibit vastly different biological behavior and disease course. Key considerations: it's not so much who has cancer, but what type of cancer it is. And it helps us decide who needs a workup, who needs a surgeon, who needs treatment. We need to know the language of TI-RADS, Bethesda categories, and know that molecular markers are playing an increasingly important role in patient management. Thank you very much for your attention. Please do feel free to email me. I'm also on Twitter, and thank you for your attention.
Our next speaker is Dr. Paul Bunch, Assistant Professor of Radiology at the Wake Forest School of Medicine. Dr. Bunch will speak to us on the workup of parathyroid adenomas, imaging strengths and weaknesses.
Hello, and thank you for tuning in. My name is Paul Bunch, and I'm a neuroradiologist at Wake Forest. I will be speaking on imaging of primary hyperparathyroidism, emphasizing the strengths and also the weaknesses of the most commonly used imaging techniques. I'm incredibly appreciative of Dr. Ilona Schmalfus for inviting me to speak on this topic. I'm also grateful for the many friends and mentors I've gotten to know in this society, and I'm very much looking forward to connecting in person someday. I have nothing to disclose. After hearing this talk, it is my hope that you will understand the role and rationale of imaging in primary hyperparathyroidism, know the available localization techniques, and be able to describe the relative advantages and disadvantages of each, and finally be able to explain what the surgeon wants to know from parathyroid imaging and why this information is important for the care of the patient. Here's an outline of what I will discuss in an attempt to accomplish these goals. Time permitting, I will walk you through some illustrative cases that I hope will help bring everything together for you before finishing with the summary. This is as simple as I can possibly make the endocrinology, and in a lot of ways, it's all you really need to know. Parathyroid hormone acts through various mechanisms to increase serum calcium. When an intrinsic abnormality of the parathyroid glands results in excessive secretion of PTH, this is called primary hyperparathyroidism, and it's the only flavor of hyperparathyroidism with which we're concerned today. Primary hyperparathyroidism represents the most common cause of hypercalcemia. The risk increases with age, and the disease more commonly affects women than men. Classic clinical symptoms of primary hyperparathyroidism relate to skeletal disease, kidney stones, and cognitive effects. However, primary hyperparathyroidism has also been shown to increase risk of heart attack, stroke, and death. Thus, primary hyperparathyroidism is a substantial contributor to overall healthcare costs. Importantly, primary hyperparathyroidism is diagnosed with blood tests, specifically serum calcium and serum PTH. Thus, imaging has no role in diagnosis. Most commonly, the underlying cause is a single parathyroid adenoma. Less commonly, the cause is an abnormality of multiple glands, and rarely it's actually a parathyroid cancer. Primary hyperparathyroidism is cured by removing the abnormal parathyroid tissue. There are two accepted parathyroid operative strategies, and I think it's worth knowing a little bit about both. The bilateral neck exploration is the original operation and involves the surgeon's visual and tactile inspection of all the parathyroid glands. The glands judged by the surgeon to be diseased are then removed. Bilateral neck exploration involves a relatively large midline incision, and because it's a bilateral operation, both recurrent laryngeal nerves are at risk for operative injury. The good news is that there are excellent long-term cure rates with low morbidity and experienced hands. The minimally invasive parathyroidectomy is a newer operation and the preferred operation when appropriate. This is a single gland operation, and as such, a prerequisite is confident and precise preoperative localization of a single adenoma. This operation has been well studied by the surgeons, and demonstrated benefits relative to bilateral neck exploration are summarized on the slide. Importantly, the cure rates with the minimally invasive approach are equivalent to bilateral neck exploration in experienced hands. Thus, the goal of imaging is localization, not diagnosis. Localization of a single adenoma facilitates minimally invasive surgery and all of its associated benefits. Localization of multi-gland disease aids in bilateral neck exploration. It's a more involved operation, but the good news is the surgeon knows preoperatively where the glands are located. In the absence of an imaging target, the patient still needs surgery to remove the abnormal tissue that the biochemical tests tell us is there. However, bilateral neck exploration will be necessary. Before moving on to imaging techniques, I'd like to briefly review parathyroid anatomy and embryology because I believe this knowledge improves our chances of finding the abnormal parathyroid tissue, no matter what imaging modality or modalities we're using in our search. Most commonly, there are 4 parathyroid glands, 2 superior and 2 inferior. The superior parathyroid glands derive from the 4th pharyngeal pouch, and their relatively limited embryologic migration is thought to account for their relatively constant position, typically found along the posterior superior aspect of the thyroid gland. The inferior parathyroid glands derive from the third pharyngeal pouch, as does the thymus. It is thought that their relatively long inferior migration to reach final anatomic position accounts for their more variable position, spanning the mandibular angle to the pericardium, though roughly half the time they are found within 1 centimeter of the thyroid gland lower pole. Note that as viewed from the front, there appears to be a lot of overlap between the distribution of superior parathyroid glands outlined in red and the distribution of inferior parathyroid glands outlined in blue. But something interesting happens when we view this same anatomic information from the side. The superior glands cluster posteriorly within the neck and the inferior glands anteriorly. We'll talk more about this on the next slide, but the line of demarcation is formed by the plane of the recurrent laryngeal nerve. Okay, so here's a potentially counterintuitive but nonetheless true and important fact. Relative superior or inferior position of a parathyroid gland does not reliably denote embryologic origin. Not infrequently, an enlarged superior parathyroid gland will descend into the superior mediastinum, a phenomenon referred to by the surgeons as acquired ectopia, and this can actually be clinically relevant, as I will show you later. What does reliably denote embryologic origin is the plane of the recurrent laryngeal nerve, which we can think of as approximated by the tracheoesophageal groove. Superior glands lie posterior to the tracheoesophageal groove, and the inferior glands lie anteriorly. If it helps, you can think of the P's in superior and posterior, and the N's in inferior and anterior sticking together. Very briefly, I'd like to mention ectopic parathyroid glands, which occur not infrequently. The inferior glands are more commonly ectopic, and here are a few examples of ectopic parathyroid adenomas identified by 4D CT. Before we depart the anatomy and embryology, there's one more important point that needs to be made, which relates to the relationship between the right subclavian artery and the right recurrent laryngeal nerve. Time does not permit me to walk you through the embryology in detail, but what you should know is that when there is a normal course of the right subclavian artery, there should also be a normal course of the right recurrent laryngeal nerve. In the setting of an aberrant right subclavian artery, there is an abnormal and unpredictable course of that same nerve, which is now referred to as a non-recurrent laryngeal nerve. As a result, there is increased risk of operative injury to the non-recurrent laryngeal nerve, particularly if the surgeon is not alerted to its presence preoperatively. Thus, for any patient undergoing preoperative parathyroid localization, regardless of the imaging modality or modalities being used, I would encourage you to report the presence of an aberrant right subclavian artery in your impression. I should mention for completeness' sake that the same is true for the left recurrent laryngeal nerve in the setting of a right aortic arch with aberrant left subclavian artery, though this is, of course, far less common. All right, this brings us to our imaging armamentarium. I will spend most of the time discussing the techniques that I consider to be widely used, but will briefly touch on some very promising techniques that I consider to fall into the emerging category. I should also say that in the individual discussion of each modality, radiation considerations will be noticeably absent, and this is because I will discuss these separately after giving an overview of the various widely used techniques. Now, it is my understanding that 4D MRI has become routinely used at some institutions, and may be shifting to the widely used category. But based on my understanding of the current state of parathyroid imaging in most practices, I have chosen to consider this as an emerging technique for the purposes of this particular talk. I'd like to attempt to frame the subsequent discussion by sharing some of my personal opinions. I think that all parathyroid imaging modalities have value. There is no single best technique for all situations. A combination of techniques is often appropriate to maximize surgeon confidence in localization via concordant imaging results. Because of the fact that only patients with biochemically proven primary hyperparathyroidism should undergo imaging, and because our role as imagers is to precisely localize parathyroid lesions, I will focus on sensitivity and positive predictive value as the most relevant measures of test performance. I believe we should strive to figure out how to use any and all imaging techniques, existing or still to come, to appropriately select patients who can be cured with minimally invasive surgery, and in the process allow those selected patients to receive the various proven benefits of the minimally invasive approach. The first imaging modality I will discuss is ultrasound, which should be performed with a high-frequency linear transducer. The examination should include the entire anterior cervical region with special attention paid to the posterior and inferior margins of the thyroid gland. Parathyroid adenomas will almost always appear homogeneously hypoechoic relative to the normal thyroid parenchyma. Occasionally, parathyroid lesions will exhibit a more heterogeneous appearance, which may relate to cystic degeneration, fat deposition, calcification, hemorrhage, or fibrosis. The presence of a polar vessel aids in differentiating a parathyroid lesion from a lymph node and its higher blood supply. One of the main advantages of ultrasound is its widespread availability. In many practices, including mine, this examination may be performed by the surgeon in his or her office. Ultrasound is the optimal modality for assessing concurrent thyroid pathology, and in experienced hands, the sensitivity and positive predictive value as reported in a meta-analysis are both quite good. The images demonstrate the typical homogeneously hypoechoic appearance of parathyroid adenomas in two different patients. Disadvantages of ultrasound include its operator-dependent nature and its inability to detect parathyroid lesions in locations for which there is no acoustic window. Ultrasound is relatively insensitive for detecting mildly enlarged glands and multi-gland disease. Effectiveness is also a function of body habitus. The images demonstrate atypical appearances of parathyroid adenomas in two different patients. The top lesion demonstrates areas of cystic change and calcification, though it is overall hypoechoic as expected. The bottom lesion is unusual in that it is predominantly isoechoic to the adjacent thyroid parenchyma, though some internal hypoechoic areas are present. The next imaging modality is nuclear medicine. The principal radiopharmaceutical agent is technetium-99m cestamide, which accumulates in the thyroid and parathyroid glands in proportion to metabolic activity and blood flow. Multiple parathyroid scintigraphy protocols have been developed, but the dual-phase single-isotope technique using cestamide is both the simplest and most widely used. Following radiotracer administration, planar images of the neck and mediastinum are obtained at early and delayed time points. The injected cestamide rapidly accumulates in both thyroid and parathyroid tissue, but the radiotracer washes out of most parathyroid adenomas more slowly than it washes out of normal thyroid and normal parathyroid tissue. As such, a parathyroid adenoma will appear as the focus of radiotracer accumulation on early images that becomes more intense relative to the thyroid parenchyma on the delayed images. Although some centers may require only planar images, most add SPECT, and possibly also SPECT-CT. A SPECT acquisition adds time but no additional radiation exposure and improves contrast resolution. The CT acquisition conveys increased patient radiation exposure, but allows for the combination of functional and anatomic information into a fused image data set. Advantages of cestamide include its relative operator-independent effectiveness, as well as its improved detection of ectopic and far posterior lesions that ultrasound is prone to miss. The sensitivity and positive predictive values listed from a meta-analysis are for planar imaging, SPECT, and SPECT-CT respectively. Here is an example to illustrate the improved contrast resolution associated with SPECT. In the projection images, on a very good day, you might wonder whether there's some faint radiotracer accumulation here on the left, but the SPECT really leaves no doubt. Disadvantages of cestamide include the relatively poor anatomic resolution. Motion artifacts can be problematic because of relatively long image acquisitions. This technique is relatively insensitive to multi-gland disease, and there is the potential for false positives in the setting of thyroid nodules and cervical nodal metastases. 4D CT is more simply conceived of as multi-phase CT of the neck and upper mediastinum. The optimal number of CT phases has not been established. However, the results of an international survey tell us that the most commonly used protocol involves 3 CT acquisitions: a non-contrast phase, an arterial phase, and a venous phase, and such a protocol is what I use at Wake Forest. Advantages of 4D CT include high-resolution anatomic information displayed in multiple planes, short image acquisition, overall superior performance in most, but certainly not all, comparative studies, and perhaps more importantly, high performance in several challenging clinical situations, such as patients with non-localizing, inconclusive, or discordant ultrasound and cestamide results, as well as among patients with a previous failed parathyroid operation. In terms of disadvantages, the interpretation of this examination can be fairly time-consuming, and there's a learning curve in terms of reaching the level of test performance described in the literature for this technique. The need for iodinated contrast media administration disqualifies some patients from undergoing this study. What will adenomas look like on 4D CT? Well, they should always be hypodense relative to normal thyroid parenchyma on the non-contrast phase. When I say normal thyroid parenchyma, I mean something looking like this, with normal iodine content. Sometimes, for example in patients with chronic hypothyroidism, the thyroid gland will look like this, with very little, if any, iodine content. And so a parathyroid adenoma may very well look more isodense to a thyroid gland like this one, and these are certainly more challenging cases to read. The classic parathyroid adenoma enhancement pattern is well described, in which the lesion will appear hyperdense relative to the normal thyroid gland on the arterial phase, and hypodense or washed out relative to the thyroid gland on the venous phase. However, only 20% of parathyroid adenomas will exhibit this classic enhancement pattern. Just like in ultrasound, the presence of a polar vessel should increase your confidence that a lesion is of parathyroid origin. We said that the majority of parathyroid adenomas do not exhibit the classic enhancement pattern, and here are examples of variant enhancement patterns taken from 2 different patients. As we mentioned with ultrasound, parathyroid adenomas may exhibit cystic degeneration, fat deposition, or calcification, and so keep this in mind when interpreting CT. Selective venous sampling is an invasive localization technique typically reserved for patients with persistent or recurrent disease following failed surgery and when postoperative non-invasive imaging studies have not yielded a confident localization. The procedure involves collecting blood samples at a number of locations within the neck and mediastinum in an attempt to regionalize, or at the very least lateralize, the site of excessive parathyroid hormone production on the basis of venous PTH concentrations and the fact that parathyroid glands typically drain ipsilaterally and inferiorly relative to their anatomic location. The principal advantage of this technique is that it may enable curative minimally invasive surgery in patients who would otherwise require bilateral neck exploration, or who may even be considered too high risk for repeat surgery without an imaging target. Selective venous sampling may also be combined with catheter angiography, as shown here where the parathyroid adenoma appears as a blush of contrast behind the left clavicular head. Disadvantages of selective venous sampling include its invasive and time-intensive nature, procedure-related risks, high cost, and the potential for false regionalization or even false lateralization associated with altered postoperative or congenital anatomic variant venous drainage. Okay, so how about radiation exposure? Among the techniques discussed thus far, ultrasound is uniquely associated with no ionizing radiation. Although 4D-CT is associated with higher radiation exposure than Sestamib-SPECT and Sestamib-SPECT-CT, the magnitude of the dose difference depends on institution-specific protocol settings. Based on work by Dr. Jenny Hong and others using the Beer-7 risk model and assuming a typical middle-aged female patient, both 4D-CT and Sestamib-SPECT-CT are associated with low absolute increases in lifetime cancer risk above the 46% baseline risk. Although I believe that radiation exposure considerations could certainly justify using ultrasound as a first-line imaging modality, I don't think we're serving our patients well if we allow concerns regarding radiation-induced cancer to feature heavily in selecting between Sestamib and 4D-CT for most primary hyperparathyroidism patients. Okay, what about costs? Well, published data suggests that from the standpoint of simply undergoing the test, ultrasound is the cheapest, Sestamib and 4D-CT are comparable and intermediate, and selective venous sampling is the most costly. However, a model published by Dr. Carrie Lubitz and others attempting to more comprehensively account for things like the prevalence of parathyroid adenoma compared with multi-gland disease, relative test performance, and the associated impact on the operative plan found ultrasound followed by 4D-CT as a second-line test, if necessary, to be the most cost-effective strategy. A few words on the emerging techniques, ultrasound elastography, PET, and 4D MRI. Elastography involves the non-invasive assessment of tissue stiffness, analogous to manual palpation. The rationale for applying elastography to parathyroid imaging relates to the high adipose content of normal parathyroid glands and the presence of a fibrous capsule surrounding parathyroid adenomas. In the future, elastography may contribute to improved accuracy of ultrasound and preoperative localization. PET provides functional information analogous to scintigraphy with substantially improved spatial resolution. Among the PET radiopharmaceutical agents investigated for parathyroid imaging thus far, methionine and fluorocholine seem most promising. Methionine is a precursor amino acid for parathyroid hormone, and choline is a precursor for cell membrane synthesis. In small studies, both of these techniques have shown very high sensitivity and positive predictive value. Multiphase, or 4D MRI, offers the potential for performance comparable to 4D-CT without the associated radiation exposure. Disadvantages include relative cost, MRI safety issues, inability of some patients to tolerate MRI, and gadolinium contrast administration required for perfusion assessment. Before showing a few illustrative cases and wrapping up, I hope to provide you with a practical approach to parathyroid imaging that will serve you well regardless of the imaging modality or modalities that you use in your practice. My goal in interpreting a parathyroid imaging study is to provide the surgeon with a detailed and accurate roadmap of the patient's neck, meticulously describing where the abnormal parathyroid tissue is located with respect to relevant surgical landmarks. The good news is that differential diagnosis is limited, mainly thyroid nodule, lymph node, and blood vessel. The challenge is that the parathyroid lesions are often small and are variable in both location and number. As such, high-quality images, again, regardless of modality used, are an absolute necessity. To select the appropriate parathyroid surgery, these are the things the surgeon needs us to address, and they're fortunately pretty straightforward. Number, size, and location of candidate parathyroid lesions, and your opinion of what each candidate lesion most likely represents. It's intuitive that a single lesion is more likely to represent a parathyroid adenoma, whereas multiple lesions are more likely to represent multi-gland disease. But what about in the setting of no lesions? Well, the biochemical results haven't changed, and those results tell us that abnormal parathyroid tissue is present despite the fact that we haven't found it. In the absence of a target on imaging, bilateral neck exploration will be necessary. Now let's assume we have a single lesion. The bigger it is, the more likely it's an adenoma, and the patient will be cured by minimally invasive surgery. However, according to data from 4D-CT, a patient with only one lesion found by imaging is statistically more likely to have multi-gland disease rather than an adenoma if that lesion measures less than 7 millimeters in maximum diameter, such that bilateral neck exploration will likely be necessary in this patient subset. This is a list of landmarks that surgeons have told me are most helpful, and I'm going to expand upon these first two. We've already talked about how the tracheoesophageal groove is a useful approximation of the plane of the recurrent laryngeal nerve, which divides the superior glands lying posteriorly from the inferior glands lying anteriorly. By describing the position of parathyroid lesions as anterior or posterior to the tracheoesophageal groove, you're not only telling the surgeon whether it is an inferior or superior gland, but you're also giving important information as to the risk to the recurrent laryngeal nerve during the operative approach. With respect to SI orientation, my surgeons have asked me to describe lesions with respect to the cricoid cartilage. I'm told the cricoid cartilage is a useful landmark because it is consistently palpable, routinely visualized in their standard operative field, and orients the surgeon to the anatomic midline, which can be surprisingly difficult to figure out in the reoperative neck. Refreshingly, the surgeons want to know what we think each candidate lesion represents. If presented with high and low confidence lesions in the same patient, they will often start with a minimally invasive approach to the high confidence lesion and plan to convert to bilateral neck exploration if the intraoperative parathyroid hormone does not drop as expected. Practically speaking, if I can't confidently determine that a structure is thyroid, a lymph node, or vascular, I'm typically describing that structure as a candidate parathyroid lesion in my report. On CT, if you can identify hyperdensity on the non-contrast phase, like in the circled right tracheoesophageal groove lesion, you can be pretty confident that's an exophytic thyroid nodule rather than a parathyroid adenoma. On ultrasound, a hyperechoic lesion is more likely an exophytic thyroid nodule because parathyroid adenomas are almost always homogeneously hypoechoic. On CT, lymph nodes will exhibit progressive enhancement, and on both CT and ultrasound, you may be able to identify a fatty highlight. So that covers what the surgeon needs to know from us to select the most appropriate operation. I want to also touch on two things we should look for to keep the surgeon, and by extension the patient and ourselves, out of trouble. The first we've already talked about, arterial anomalies associated with a non-recurrent laryngeal nerve. The second is concurrent thyroid pathology. No surgeon wants to perform the perfect parathyroid operation and leave a thyroid cancer behind. So if we're already performing an ultrasound, great, we can get the optimal evaluation of the thyroid gland at the same time. If performing 4D CT or sesame SPECT CT and we notice something potentially worrisome in the thyroid gland, we should alert our surgeon so that they can, at a minimum, get a preoperative ultrasound, possibly also an FNA, and if necessary, potentially perform a concurrent thyroid resection at the time of parathyroid surgery. All right, let's try to cement some of these concepts with illustrative cases. Case 1 is a 76-year-old female with primary hyperparathyroidism. She initially underwent a sesame study. Planar images showed a lesion in the left lower neck, which corresponds to this left paraesophageal lesion on SPECT CT. Those images were acquired elsewhere, and I don't know how they were reported, but I do have the outside operative note with relevant portions of the text highlighted here. The operative note goes on to say that the left inferior parathyroid gland was identified and removed. Intraoperative PTH was not performed. Well, 3 months after surgery, the patient's calcium is 11.5, so she undergoes a 4D CT, which shows this. Now, in my opinion, this is almost certainly the same lesion we saw preoperatively, and it is not a left inferior parathyroid adenoma. Rather, it is an example of an inferiorly descended left superior parathyroid adenoma, the phenomenon the surgeons referred to as acquired ectopia. Now, there are certainly a number of things we can wonder about as to why the initial operation failed to cure this patient, but what I hope you will take away from this is a reminder that it is not purely academic whether a parathyroid lesion is of superior or inferior embryologic origin, as this determination informs the necessary depth of the operative approach as well as the associated risks to the recurrent laryngeal nerve. Case 2 is an 82-year-old male with primary hyperparathyroidism. He initially underwent an ultrasound in the surgeon's office, which identified a suspicious lesion along the posterior aspect of the right thyroid lobe, and a 4D CT was ordered because this particular surgeon prefers to have at least 2 concordant imaging results before offering minimally invasive surgery. Okay, so here's the lesion of interest on 4D CT. It appears hypodense on the non-contrast phase. That's good for adenoma. It appears hyperdense on the arterial phase, which is also good, and it remains hyperdense on the venous phase, which is not classic, but we now know that the classic appearance is actually seen in the minority of adenomas. Well, I always want to use all the information available to me, right? So let's look at the surgeon's ultrasound images of this lesion. The circled lesion is hyperechoic relative to the adjacent thyroid parenchyma highlighted by the arrows. We'll never say never, but that would be very unusual for a parathyroid adenoma. So now, based entirely on the ultrasound, I'm now thinking this is more likely to be a thyroid nodule. Well, I keep looking at the 4D CT, and I find this left superior parathyroid adenoma with a very nice polar vessel sign. This lesion is so far posterior and tucked behind the esophagus that it's not surprising that this wasn't identified by ultrasound. The surgeon removed the left superior lesion minimally invasively, and the intraoperative parathyroid hormone dropped as expected. The lesion on the right was a thyroid nodule, and the ultrasound images were actually the most useful piece of information in figuring that out on CT. Okay, last case. A 68-year-old male presents to our emergency department with numbness and slurred speech. He undergoes a head and neck CTA on which I identify what I thought was a 1.6 centimeter thyroid nodule and for which I recommended an ultrasound. Well, on the ultrasound, the caliper is on the left thyroid lobe, and this hypoechoic lesion deep to it appears to be outside the thyroid gland. Do a little digging, and it turns out the calcium is 13, and the PTH is inappropriately normal. This patient hasn't gone to surgery yet, but it sure looks like what I called a thyroid nodule is in fact a left superior parathyroid adenoma. And if I put back up the next CTA image, there are 1 or 2 slices where a fat plant is probably visible between the presumed adenoma and the thyroid gland. So I think the take-home points here are, number 1, clinical context matters. And number 2, I'm thankful for the smart people interpreting the parathyroid ultrasound and sesame studies, just as I hope those individuals appreciate the efforts I'm putting into parathyroid CT. I believe our patients are best served by having the entire imaging armamentarium available for the reasons we've repeatedly touched on throughout this talk. In summary, primary hyperparathyroidism is associated with substantial morbidity and costs. The disease is diagnosed biochemically and cured with surgery. The role of imaging is preoperative localization, and our knowledge of embryology and anatomy maximizes localization success. It is my personal belief that we best serve our patients by leveraging the strengths of all parathyroid imaging modalities to maximize access to curative minimally invasive surgery for those patients with single parathyroid adenomas. This table summarizes what the surgeon wants to know in order to plan and execute the appropriate operation. I won't read it to you, but you have it now and can refer to it if you choose to when interpreting any parathyroid imaging modality. In closing, I'd like to again thank Dr. Ilona Schmalfus for the invitation to speak. I'd also like to acknowledge these two outstanding radiologists for teaching me just about everything I know about parathyroid imaging, these three surgeons for teaching me the rest of what I know, and finally, Dr. Valerie George for creating the illustrations in this presentation. Thank you for tuning in, and I hope you learned something.
It's my great pleasure to introduce our last speaker, Dr. Girish Vatharpakkar. He is our section chief of neuroradiology at NYU Langone Medical Center, and he's going to be presenting the pituitary gland and paracellular pathology.
Hi friends, this is Dr. Vatharpakkar, Associate Professor of Radiology at NYU School of Medicine. It is indeed a pleasure and an honor to present state-of-the-art imaging of the pituitary gland at this ASHNR 2020 conference, so thank you for the invitation. I have no disclosures. The pituitary gland is the seat of endocrine homeostasis, and I will start my talk by asking a basic question. Does the pituitary gland lie inside or outside the blood-brain barrier? Well, after administration of contrast, the pituitary gland enhances homogeneously, which tells me that it lies outside the blood-brain barrier, which we exploit when we obtain dynamic imaging of the pituitary gland. So what I would like to do in the next 15 to 20 minutes is to provide you with an overview of the state-of-the-art imaging of the pituitary gland utilizing grasp permeability imaging, and by doing so, I will go a little bit into the physics of the sequence, tell you a little bit about the advantages that it has over conventional dynamic imaging before delving into the clinical applications. So here is a study that was obtained way back in 2013 or 2014, and I'll tell you that there is a microadenoma that is present. This was obtained at NYU. At that time, we were doing 3 millimeter thick scans. I really cannot see the microadenoma, obviously because these were 3 millimeter thick scans. And that is the problem with dynamic imaging of the pituitary gland. There's no standardization. Variable slice thickness, variable slice interval, variable duration of the dynamic sequence, which I think is important because it goes into the economics of imaging. What is the appropriate time window to obtain the dynamic images of the pituitary gland? Is it 2 minutes, 3 minutes, 5 minutes? And before I discuss that, let us go back to this particular case. Microadenoma not seen. Soon after, we started obtaining dynamic imaging of the pituitary gland using grasp with radial vibe. And here is such a study. Granted, it's more noisy, but I do see the microadenoma just off the midline to the right, and it is possible because of the higher spatial sub-millimeter resolution, higher temporal resolution, which is less than 20 seconds a frame. We can combine this with grasp permeability images, color maps, which allows us to see the microadenoma as a focal area of different color and much more easily, allowing us to evaluate these lesions with more confidence. Perhaps a better role to play when it comes to evaluating Cushing's syndrome, where the microadenomas are really, really small. Typically, when we obtain an MR, we sample the case space in a Cartesian manner, and that takes a lot of time. If we were to the case space in a radial manner, as is done utilizing the radial wipe sequence, we can sample the center of the case space, and by doing that, we can obtain images which can give us enough information as well. Because the sequences run much faster, it is more robust to any motion artifact. It has an inherent fat suppression built in, which allows us to appreciate the anatomy and pathology much better, as can be seen here with these images as you compare the Cartesian to the radial wipe sequence. In the orbit itself, look at the phenomenal anatomical resolution of the globe when you compare the radial wipe with the conventional images. Taking it to pathology, the left optic nerve sheath meningioma is much better seen utilizing the radial wipe sequence because it has a much better fat suppression built in as compared to the conventional images. Furthermore, it has multiplanar capability, which allows us to assess the pathology and anatomy at multiple planes and therefore provide a more complete evaluation on the study performed. When one combines the radial wipe with the grasp, then it allows us to get dynamic information in a single continuous scan, which then builds into the temporal resolution, allowing us to get better dynamic information from the study obtained. This, when combined with permeability, such as the enhancement time curve as shown here, the yellow font is from the jugular vein, the contrast is picked up and then it is washed out. It tells me it's a good bolus of contrast. The thyroid gland is vascular, so in the green font you can see the contrast washing into the thyroid gland. It gradually washes out, versus from the lesion in the red font where it picks up the contrast gradually, not as quickly as from the jugular vein or the thyroid gland, and then gradually leaks out of contrast. This leakage of contrast can be assessed, quantified, and helps us in diagnosing the underlying lesion better, as well as in telling us in follow-up studies about recurrence or treatment-related change better as well, which is not the focus of this talk. So, the radial wipe sequence provides us excellent anatomic information, and when combined with grasp, it allows for functional evaluation and therefore allows us to contribute to our interpretation of the study much better. It is better done on the 3 Tesla scanner. A wide area of coverage is possible, yet it gives you phenomenal spatial resolution, which is sub-millimeter. The permeability color maps can be obtained utilizing various permeability measures, as well as the enhancement time curves allows us to assess the lesion better. We noticed that utilizing these enhancement time curves, the enhancement of the anterior pituitary gland was slightly more delayed as compared to the posterior pituitary gland, though it was more robust. But importantly so, we noticed that after 70 seconds, the contrast absolutely plateaued off within the anterior and posterior pituitary gland, and therefore up to 110 seconds, if one scans the pituitary gland, it's good enough. We at NYU continue till about 180 seconds, because if we were to cut short to 110 seconds, then there would be a lot of noise that would remain in the images, and that would be a limitation. So to compensate for the noise, we continue over 180 seconds, but 110 seconds is good enough. Look at the phenomenal resolution here. The enhancement of the pituitary gland starts at the top, goes to the bottom, and then from the center to the periphery. Again, this appreciation is possible only because of the phenomenal spatial and temporal resolution. As I mentioned, the enhancement of the posterior pituitary gland occurs sooner than the anterior pituitary gland, but the enhancement of the anterior pituitary gland is more robust because it goes through a widespread hypophyseal portal system. That is because of the differences in the blood supply. The posterior pituitary gland receives its blood supply from the inferior hypophyseal artery, which reaches the posterior pituitary gland sooner than the anterior pituitary gland, which receives its blood supply from the superior hypophyseal artery, which goes through a network of the portal plexus, and therefore a slightly delayed but in a more robust manner. Clinical applications. Here is a 16-year-old boy with growth hormone disturbances. I know it is a central cause. I look at the images. There's no focal area of differential enhancement. I know that the study looks normal, but it is not normal. So we hypothesize that this is related to clinical hypopituitarism without any structural abnormality could be associated with abnormal perfusion of the pituitary gland. So we utilize grasp images with radial, and when we look at the permeability measures, here in the Gaussian measures, even on the color maps, you can see the enhancement of the pituitary gland in the hypopit patient is just not as pronounced as it is with the normal control group, and that difference is statistically significant. Similar measures were possible even in the washout permeability measure, again statistically significant. So we concluded that there is definitely a role for physiologic imaging, especially in morphologically normal pituitary gland patients, in patients with central endocrine disturbances. This was demonstrated by Wang et al. Way back in 2011, utilizing perfusion imaging of the pituitary gland, whereas we employed permeability imaging. Here is a cystic appearing lesion seen within the pituitary gland. Well, is it a cyst or a microadenoma? Without endocrine information or history, I cannot distinguish the two. But using the permeability maps, notice here the lesion picks up the contrast, just not as robustly as the anterior posterior pituitary gland, which tells me that this is a cystic microadenoma. Is a similar appearing case which demonstrates a cyst-like lesion. In this particular case, the cyst does not pick up any contrast at all, which tells me that this is a cyst and not a cystic microadenoma. So without the history, I can distinguish the two. Here is a patient with a cellar appearing lesion that extends in the supracellular compartment. Well, the diagnosis is relatively simple. It's a macroadenoma, but the key thing here is to go beyond and tell the surgeon where is the pituitary gland. So utilizing the permeability maps, I can see in this particular case the pituitary gland is located to the right of this lesion and along the superior aspect, to the left of this lesion and along the superior aspect. It had a 100% correlate with intraoperative exploration when excising the macroadenoma. This, if we tell the surgeon where the pituitary gland lies before the surgery, reduces OR time, and therein lies the benefit of utilizing this particular sequence in preoperative evaluation of macroadenoma. What about differential diagnosis of macroadenoma? Well, here is a 45-year-old woman with headaches, prolactin level of 30. Started on bromocriptine empirically, stopped for some time. This is a preoperative study, read as a possible macroadenoma. There is a lesion seen which expands the cella extending into supracellular compartment. Prior study, the lesion appeared more obvious. The surgeon looked at this case and thought, well, the lesion looks smaller, no strong story for macroadenoma. Could this be perimenopausal pituitary hyperplasia? Patient insists on surgery. Can you take a look? So I turned to my new best friend in imaging, which is imaging. And here, unlike the prior case, the entire gland or the lesion seemed to enhance more robustly. There was no focal area of differential enhancement. I said, suspicion confirmed, this is pituitary hyperplasia, follow-up recommended, surgery cancelled, and then I was hoping and praying that I would. Follow-up study was obtained. Now the lesion has shrunk in size. Diagnosis confirmed as pituitary hyperplasia. 24-year-old woman with headaches and visual complaints. Here is a cellar-based mass extending into the supracellular compartment. Diagnosis, well, one would think in terms of a macroadenoma for sure. Permeability images, like the immediate prior case, shows robust enhancement. There's no focal area of differential enhancement seen that would suggest where the pituitary gland would lie. I therefore thought of going back to the history. Went back, this was 1 month postpartum, and therefore diagnosis to be postpartum pituitary hypophysitis, which is what this turned out to be. It is a classic adenoma mimic. History remains the key, and it is a granulomatous autoimmune sort of form of hypophysitis. Important thing is to make the diagnosis because there's no surgery required. Observation and steroids and the lesion will disappear. Another case, 46-year-old woman with headaches, known case of meningioma, operated at an outside institution. The lesion is seen in the supracellular compartment, as you can see it here. But then the surgeon was asking me, well, where is the pituitary gland? Where is the meningioma? Can you distinguish the two? And based on these images I obtained at an outside institution, it was literally impossible. So I went back to my best friend in imaging, grasped on the early dynamic phase. I can see the meningioma enhances early. It obeys the mother-in-law sign, comes in early, stays late. It is living along the diaphragma sella, as can be seen here. It abuts the stalk. The pituitary gland so far does not show any enhancement. And then at a later stage, both the pituitary gland also enhances, but I can confirm my evaluation on the enhancement time curve maps as well as the permeability maps as well, which allows for better gamma knife planning and also for surgical exploration, if any. Thus, GRASP clearly distinguishes meningioma in this particular case from the pituitary gland. We have a 3 Tesla intraoperative MR that gives us phenomenal resolution. It allows us to do advanced imaging as well. Here is a macroadenoma excised, and I can tell the surgeon that, listen, you just completely excised the macroadenoma because look at the clean intraoperative scan here. The surgical bed is absolutely clean. The surgeon has done a phenomenal job in this particular setting. So to conclude, pituitary gland imaging can be obtained in a phenomenal manner using radial wipe with GRASP because of the submillimeter spatial resolution, higher temporal resolution, which we've kept it as 20 seconds per frame, but we can go down to 5 seconds per frame. The dynamic scan duration, I told you, can be cut to about 120 seconds. That's good enough, but we extend to about 180 seconds so as to obviate the noise that can creep into the image. It is an inherent fat suppressed sequence, and therefore it allows in the post-operative setting, which I could not get into because of the interest of time. Furthermore, it allows for permeability imaging of the pituitary gland, allowing me greater confidence in interpreting. There were some of the applications that I discussed with you guys. Again, I hope this has been helpful. Stay safe, everybody. Thank you for your time and attention.